introducing Rosina Stamati today. So Rosina is clinical coordinator for the pharmacy program and the director of the PGY1 pharmacy practice and PGY2 geriatric pharmacy practice residency programs, and the coordinator of the Pharmacy Palliative Care Fellowship Program here at the James J. Peters Veterans Affairs Medical Center in the Bronx. Mrs. Samadi received her pharmacy degree from the Arnold and Marie Schwartz College of Pharmacy at Long Island University and her master's in public administration from Pace University. She currently holds an appointment as clinical assistant professor of pharmacy at LIU. She's been a certified geriatric pharmacist since 1997 and a board-certified pharmacotherapy specialist since 2004. Previously, she was director of pharmacy services at the Jewish Home and Hospital in the Bronx. Ms. Stamati has presented national and local education programs in geriatrics and medication-related issues for pharmacists, physicians, nurses, and other related healthcare providers. She has served as a poster reviewer for the American Society of Consultant Pharmacists and a journal reviewer for gerontology and geriatric education. So here is your presenter, Rosina.
Thank you, Jennifer. And good afternoon, everyone, and good morning to those of you that are in a different time zone. So let's get started. Today we're going to talk about polypharmacy and the Beers criteria. We'd like to, during the talk, identify practices that result in polypharmacy in your senior patients, identify drugs that are part of the Beers criteria, certainly not all of them, but a sample, and look at how medication reconciliation can help reduce polypharmacy, as well as discuss other strategies that can work to reduce polypharmacy in older patients. Those of you who may sponsor a brown bag day in the clinic or at a senior center often are confronted with this scenario where the older patient will come and start unloading their medications, a variety of bottles and tablets and capsules and other products there. They may not remember what they are or what they're used for. When you sit down and talk to them, you find that they're probably not taking the vast majority of them, but the potential is there for them to take it because it's available to them, and there is a concern for potential side effects or medication misadventures. Likewise, on the institutional side, the long-term care patient may have a very long list of medications. One of the differences between the patient that we see in a community dwelling elder and the patient that we might see in a long-term care facility or assisted living facility is that the long-term care patient is getting all the medications because usually a nurse or other caregiver is administering them on a regular basis. So it's highly likely that if the drug list is 18 or 20 drugs, that they're getting every single one of them on a regular basis. So this is something to be concerned about, and certainly we could consider, after reviewing the list of medications, that this is polypharmacy. So what might lead to polypharmacy in a senior patient? There are a number of pressures on the providers, on the prescribers, whether it's a physician, pharmacist, or nurse practitioner, and we're going to start to outline them and go in and then discuss polypharmacy. One of the things that providers use to guide therapy are evidence-based guidelines or treatment guidelines, which are the standard of care in medical practice. And there are disease guidelines for virtually every disease that's out there, and they outline treatment strategies, lifestyle changes, as well as preventative measures that can be used to mitigate some of the complications of the diseases. One of the things that we need to be concerned about when we're talking about an older patient as opposed to perhaps someone who is younger and earlier in the course of the disease is how long it would take for a drug to have the benefit that we expect. And in some of these medications, for instance, in obstructive pulmonary disease, a corticosteroid inhaler Regular use may take as long as 10 years to exert a positive effect. If you're talking about cardiovascular disease or diabetes, use of cholesterol medication may take as long as 3 to 5 years for us to see the benefits that have been seen in the clinical trials. So that's something to consider. One of the concerns we also have on an individual patient basis is medication safety. As your patient gets older, their physiology changes. It certainly changes from their baseline when they're in their 40s and 50s and as they move into their 60s and later on into their 70s and 80s. The major concern that we have with older patients, with GERE patients, is the decline in renal function because so many drugs are cleared through the kidney that this can have a significant impact on drug therapy and medication safety. Additionally, older patients have different pharmacodynamics, how the drug is handled in the body from younger patients. And there have been a number of studies. Some examples are the opioids for pain management, the narcotics, or the benzodiazepines, such as lorazepam or diazepam, Valium, that if you give the same dose to a younger patient and an older patient, you get the same blood levels. However, the pharmacologic effect in the body is different to the point where the patient may actually experience toxicity. So we need to be careful about the pharmacodynamic changes that can occur. Additionally, with the number of medications that older patients are on, we need to be concerned about drug interactions and how the drugs are cleared from the body, and any potential adverse reactions or side effects of medications that the patient may experience. And with up to a third of emergency room visits being related to an adverse drug reaction in an older patient, this is certainly a significant issue. Finally, many providers in insurance plans and in group practices may be concerned about performance measures, their report cards, how well they're doing in controlling a disease state. For diabetes patients, how many of their patients are at their target hemoglobin A1C that shows good control of the diabetes. One of the things that oftentimes in practice the providers don't particularly look at is what is the definition of the sample that's being measured. So if you talk to the typical provider, they'll say, well, all my diabetic patients need to be below an A1C below 7 or an A1C below 8. When in fact that's not true when you look at the sample size. The VA certainly and NCQA and HEDIS, when they measure the compliance with good diabetic control, the inclusion criteria are patients 18 to 75 years old. Once that patient hits 76, they're not even counted in the sample. So we need to individualize therapy for our geriatric patients based on what we need to do for them to make sure that they have good quality of life and healthy aging. So you might ask, what is polypharmacy? Well, there's been a variety of definitions. Some researchers have defined it as 5 or more medications when given together can cause adverse reactions and can be harmful to the patient. Up to 1991, those of us that were in long-term care before that know that 10 or more medications was considered the benchmark where the patient was trending towards polypharmacy. In 1991, the federal government enshrined it in the nationwide standard in long-term care for nursing homes as 9 or more medications being the cutoff for polypharmacy. And that's a quality indicator for long-term care facilities when they're being surveyed either by the Long-Term Care Institute or their state survey teams. The VA for outpatients considers 15 or more prescriptions polypharmacy, where they caution the provider to stop and look at the medications and determine if it's appropriate to continue all of them and to please review them. But there are no clear definitive underlying studies for any of these numbers other than a general sense of increasing number of meds causing problems. One of the challenges we also have is how many medications is the patient actually on? Not only do we not always know as providers, some studies out there have included only oral or injectable prescription drugs and ignored everything else. But Center for Medicaid and Medicare Services, in their regulatory criteria, includes everything: prescription drugs, non-prescription medications that the patient may be buying on their own or be prescribed by their provider, topical preparation, any herbals that they may be buying over the internet or through a radio program, supplements, vitamins, and as-needed medications when they're actually used. So if they're using that acetaminophen propane 2 or 3 times a week, it should be counted if that's when you're evaluating their medication list. So we also want to know with the PRNs how often they're using the medications and get rid of them if they're not needed. One thing we do know about polypharmacy is that the greater the number of medications, the greater the risk for drug interactions, medication errors, and adverse effects. And this leads to increased ER visits or hospital admissions and potentially affecting mortality as well. So what are some of the causes of polypharmacy? Many of our patients have multiple chronic disease states. 50% of seniors have 3 or more chronic disease states, and some of them trend up towards 8, 9, or 10 different medical conditions that need to be managed. Disease treatment guidelines focus on a single disease. They don't take the multi-morbidity into account when they are advocating medication. But one of the things that the treatment guidelines have in common is that there are multiple drugs recommended to attain ideal treatment targets. So for diabetes, not only are you going to manage the blood sugar, but you're also going to consider putting the patient on an aspirin to prevent cardiovascular events, a statin to reduce the, reduce the cardiovascular risk and control the lipids, hypertensive meds, either to protect the kidney or control associated hypertension. So they can end up on 5, 6, or 7 different medications. Again, with heart failure, you have the actual treatment treatment drugs to reduce morbidity, as well as adjunct medications to help manage some of the potential complications. And most patients who are diagnosed with glaucoma are on more than 1 medication, sometimes 2 or 3, to help reduce the intraocular pressure. So the number of medications on the patient's drug list can grow very quickly. So how good is the evidence in the elderly behind some of these guidelines? And if you look at the type 2 diabetes trials, there was a study with 440 trials that were pulled, and they looked at how often older adults were included or excluded from the trials. And they found that 2/3 of the studies excluded older adults had an age cutoff where the patient was no longer eligible. 3/4 of the studies actually excluded patients with comorbidities, so they wanted patients where they either had diabetes alone or maybe mild hypertension. Almost 1/3 of patients with studies excluded patients with polypharmacy, and then to a lesser extent, those patients with cognitive impairment and those with a short life expectancy. And these exclusions are exactly the groups of patients that we see on a daily basis in our practices. Only 6 of the 440 trials that were conducted specifically in older patients. So there really is a paucity of data that limits the value of the evidence when you're treating older, frail, complex patients. And that's a challenge that we have when the patient is sitting across from us in the office. We also have multiple providers. The patient sees the primary care provider, and they also may see the cardiologist and the endocrinologist and the nephrologist and the ophthalmologist. And all these specialties are managing their specific condition that the patient was referred for. So they may add medications. They may not know that the patient is on other medications that are treating the same medical conditions. And there's a tendency to add medications rather than replace medications, and that can help the medication, make the medication list grow. Additionally, we have drugs that will prevent disease complications. So for osteoporosis, the older female or even a male can be on bisphosphonate, such as alendronate or Fosamax is the brand name, and in addition to that, they need calcium and vitamin D. So you have 3 drugs just to treat the osteoporosis and to prevent a fracture. Similarly, the diabetic patient can end up with 5 or 6 different drugs, and it becomes a challenge to evaluate the drug therapy. We also have a situation where a provider may think that a little bit of a medication is better than going to full therapeutic dose. So there may be the syndrome of suboptimal prescribing, where there are minimal or starting doses of multiple medications. So rather than increase the dose of a medication, they add a different medication. It opens the patients up to adverse reactions and also drug interactions. We need to be careful about the prescribing cascade, the addition of drugs to treat unrecognized side effects. The patient comes into the office, or you see the patient in a social setting and they're complaining about dizziness. Well, is the dizziness due to low blood sugar or potentially low blood pressure, or is it truly dizziness? We have to be careful about not adding an anti-vertigo agent on top of it that has its own set of side effects. And to a lesser extent these days, direct-to-consumer advertising can also promote prescribing of medications when the patients come in and demand certain meds. The patient also has challenges as to how they manage their medications. The complexity of the regimen can be overwhelming, so they don't comply with the drug therapy, or they take it inappropriately. They may have baseline cognitive function declining, and that with the medication on top of it, it becomes a vicious cycle where the cognitive function deteriorates and they have more problems with the medications. There may be a financial burden, even with Medicare Part D and even with co-pays. They may not fill all the prescriptions, or they may rotate meds. And that's a problem, because if they've been titrated to a specific dose of medication and now they stop taking it for 2 months and then go back to it, they're taking it at full therapeutic dose, and that could land them in the emergency room. Finally, physical disability can be an issue both in administering the medication. Is dexterity an issue, where they have trouble using an inhaler or an eye drop or an insulin injection? They may have vision deficits where they can't see or they can't read the label, and hearing deficits where they don't understand instructions. And they may even have access issues. Try calling an 800 number with a 10-digit prescription number to call in for your refill, or even physically getting to the pharmacy to get their medications filled. All of these can be challenges that the patient may not be willing to talk about. And as providers, we need to tease that out. Patients have been known to make medication errors in the home, and sometimes we find out about them by accident. We had a 80-odd-year-old patient come into the endocrine clinic, and he came in with very low blood sugar. We come to find out that he was taking the long-acting insulin 3 times a day instead of his mealtime insulin. He needed to be treated in the emergency room. Both insulins were clear, and he was having difficulty reading the labels. So they can get into trouble with complex regimens. Multiple providers telling them different things where therapy is duplicated, or there might be unclear instructions. The multiple drugs causing interactions, and also unrecognized adverse reactions where they just think that their disease is worsening, as opposed to it being actually an adverse drug reaction. So how do we balance polypharmacy? It can be necessary and appropriate, but the drugs need to be looked at carefully. It's undesirable when the drug is considered unnecessary, meaning that there's no current rationale for use of the drug. It's used to treat a side effect of another medication. It's not consistent with the patient belief system and what they're looking for and what they want, or the risks of using the drug outweigh the benefits. So we need to take this all into account as we adjust their drug therapy. So what tools are there available to reduce or avoid polypharmacy? And there are a couple of them. We can use medication reconciliation, which we'll talk about in a minute. The consensus-based guidelines that maybe help guide drug therapy in an older patient, and also, and probably most important, an individualized medication review to actually look at each drug that the patient's on in the context of that specific patient. So one of the first cases we're going to look at is Mr. S., and he's an 87-year-old man that came to the Jerry Clinic with his wife. He has a history of hypertension, coronary artery disease, and benign prostatic hypertrophy. I noticed in the chart that he had a recent 2-day hospitalization for syncope where he had a fall, but luckily there was no injury, no bone breaks or stitches required. So he stayed in the hospital overnight, and the team determined that the tirazosin that he was on, which lowered his blood pressure but also was primarily being used for his BPH, was what caused the syncope. It's a known side effect, and it was replaced by tamsulosin, which has a much minimized effect on blood pressure and is much less likely to cause those drops in blood pressure and reduces the risk of him falling again or passing out. Well, we interviewed the patient and his wife to review the med list, find out what he was taking, and we come to find out that the patient was taking every single drug that he had in the house, including the tirazosin, which landed him in the hospital, and the tamsulosin. So with that, we educated the patient to discontinue the tirazosin and reminded him that this is what had landed him in the hospital and possibly caused the side effect. We gave him a printed medication list to take home, and we also, importantly, posted the adverse drug reaction in the medical chart so any other providers knew that this patient had a problem with medications. And we felt confident that this patient was not going to return to the hospital with syncope. Medication reconciliation is a patient-centered approach. Since 2006, the Joint Commission has made medication reconciliation mandatory wherever they survey institutions and organizations. So at each transition of care, whether the patient shows up in the ER, on the inpatient side, at discharge, they have an ambulatory visit, they're in a home care program, or they're in long-term care, the medications need to be reconciled, and a specific clear list of medications needs to be developed. It includes prescription, non-prescription, herbal products, and supplements. So everything that the patient is taking should be on that list. It's a written list that the patient should keep with them and take to multiple providers so that everyone is looking at the same list, and it should be reviewed and updated at each interaction so that the patient knows what they should be taking. They should not be taking anything that's not on that list. And the goal is an accurate list of meds that the patient is receiving from everyone so that everyone is on the same page and there's no duplication and you minimize the potential for drug interactions. We also have geriatric prescribing criteria, and the gold standard is the Beers criteria for long-term, which was first published in 1991 for long-term care patients, and it identified common inappropriate drugs that should not be used in the elderly but could be permissible under certain circumstances. It was updated in 1997 and was also extended to all elderly, realizing that a geriatric patient was at risk regardless of what setting they were being cared for. The Canadians also did something, also developed their own list, which was very similar to the Beers criteria, but not identical. And in 1999, the Beers criteria was adopted by CMS and put in the interpretive guidelines for long-term care. So when the surveyors come to a facility, they're going to apply the Beers criteria to their medication reviews of individual residents. In 2003, the Beers criteria was updated and further incorporated into other quality guidelines, including Medicare Part D. Along the way, there were other guidelines that came out and appropriateness, medication appropriate lists that came out, such as the Medication Appropriateness Index, which is a series of questions to determine whether or not the drug should continue to be used or prescribed. The Europeans developed the START and the STOP criteria, and in fact, they compared it to Beers, but it's a list, those are lists of drugs either that should be prescribed in geriatric patients because there is significant benefit, or drugs that should be considered for stopping that they're potentially inappropriate. And then finally, in 2012, we had a comprehensive update of the Beers criteria, and that's what we're going to be focusing on today. Additionally, in 2012, the American Geriatric Society became a collaborator on the Beers criteria and also started to develop guidelines for patient-centered care with older patients with multiple chronic conditions, and started to recognize the seriousness, how the problem of polypharmacy was continuing to grow instead of get better. So there's a very strong collaboration, and many of the guidelines, there are a number of documents that are available on the AGS website. So the Beers criteria that were published in 2012 were put together by an expert panel, an interdisciplinary panel of pharmacists, physicians, and NPs. And they were charged with looking at the existing guidelines and either removing or adding medications. And the criteria for making the changes was to look at the evidence that was behind the recommendations using a systematic review of the literature, grading the evidence as far as quality, was it high quality, was it low quality, and then a focus on geriatric specific concerns so that if it was a drug where it applied to all patients, it was not necessarily on the list. It was more geriatric focused. So they ended up with a final list of 53 classes of potentially inappropriate medications. And they were broken into 3 categories. Potentially inappropriate meds that in any patient need to be reevaluated. Potentially inappropriate meds where a certain disease state exists or syndrome exists in the patient. And also medications, a new category of medications to be used with caution in the older patients. And it included prescription and non-prescription meds. So, for example, in the first category, selected inappropriate medications, I listed a few of them. I also highlighted the changes from the 2003 guidelines for those of you that were that might be familiar with the guidelines. And one of the additions was the short-acting benzodiazepines in addition to the long-acting, because they found that in geriatric patients, they also had a prolonged half-life beyond the 6 to 8 hours that might be considered the desirable timeline. So the recommendation with the benzos is that they be avoided for insomnia, agitation, or dementia in all patients. One big addition, and one that a lot of facilities, including ours, is struggling with, is the avoidance of sliding scale insulin. It's so ingrained into institutional practice that it really requires a prolonged educational change to move away from sliding scale insulin, which is a reactive approach. The blood sugar goes high and the insulin is administered dropping the blood sugar. The studies have shown that there is a high risk of hypoglycemia without improvement in diabetes control, regardless of the setting, whether it's hospital or long-term care. And it puts the patient at risk, particularly the geriatric patient. And while hypoglycemia is undesirable, we need to determine what our targets for treatment are. The newer sleep medications, such as Zolpidem or Ambien, Esclopicone, and Zaloplan, are now on the list because the pharmacodynamic effect in the body of a senior patient is similar to benzodiazepines, and there's small benefit associated with the use of these drugs. So the recommendation is, if they're to be used, that it be for less than 90 days, and it be intermittent use. The other class of diabetes medications that has been on the list are the oral sulfonylureas, the long-acting agent chlorpropamide. Glyburide was added in this go-round because it's cleared through the kidney, and reduced kidney function can significantly impact the pharmacologic length of effect of the drug. So the recommendation is that it not be used and more suitable agents be chosen from this class of medications. All antiarrhythmics are now recommended not to be used, including amiodarone. Previously, amiodarone was considered appropriate to be used. It was the most desirable one because it could be used in patients with heart failure. But the concerns of the toxicities with amiodarone on the thyroid, on the kidney, on the liver, ophthalmologically, and the pulmonary complications, the determination was made that amiodarone should be added to the list, and that rate control be the main source of controlling atrial fibrillation. And finally, migestrol, which some of you may recognize as a steroid, is the most common use is for weight gain in older patients. It is FDA approved for weight gain in HIV patients at a dose of 800 milligrams, but in older patients, it's shown to have a minimal effect on positive weight gain, and it can also promote the development of clots and deep vein thromboses. So again here, with the minimal benefit, the concern was about the risk. And in fact, about 15 or 20 years ago, there was a study that was published in a long-term care facility in Maryland where they looked at their patients because they saw a spike in the rate of DVTs, and they found that the only thing associated with it was migestrol. And we all looked at our patients that had received the drug, and probably most of us found that there were a few patients that may have had a DVT while that could not be attributed to anything else. So that has fallen into, that is recommended not to be used in older patients. Likewise, there are some medications that are considered inappropriate with certain disease states. And with the dementia patient or the patient that has cognitive impairment, you want to avoid many of the sleep medications, the antipsychotics, anticholinergic drugs, because these all can affect the central nervous system functioning. So if they're having difficulty functioning in the activities of daily living and the drugs make it worse, you want to avoid it. An additional concern with the antipsychotics are the black box warnings about the increased risk of death and stroke in patients with dementia. That's well documented pretty much with all of them. So you want to avoid these drugs unless the patient clearly is harmful to themselves or others, and then the use would be appropriate with close monitoring. With patients with a diagnosis of seizure disorder, they have added other drugs to the bupropion because they can lower the seizure threshold and promote seizures. And clinically, this is of concern because you want to prevent seizures as much as possible. If a patient has a history of falls and fractures, you want to avoid medications that can potentially worsen the risk and make the patient more prone to falling, because the outcomes can be negative and can increase the mortality with a hip fracture. Patients with delirium, you want to remove any drugs that are potentially can worsen the delirium. And with some of these, such as a corticosteroid, you wouldn't just discontinue them, or a tricyclic, you wouldn't just discontinue them, you would taper them to remove the drug. And again, with heart failure, new information with the glitazones, and that's rosiglitazone and pioglitazone, which are used for diabetes, they may exacerbate heart failure due to the fluid retention, so you want to avoid these. They don't address the Beers criteria, and most of the other criteria don't address the use of alcohol in, but it's not something that is generally recommended because they can have multiple drug interactions, and it can also affect their ambulation and their functioning. So we need to be careful if a patient drinks alcohol in terms of quantifying it, and maybe actually referring them for services if it is a problem that's going to interfere with their daily functioning, because they are at risk. The last group of Beers criteria drugs that I'm going to talk about is that new group where there were a few medications that were added because they should be used with caution. Aspirin, surprisingly, to some extent, may surprise us on the list if it's being used for primary prevention of cardiac events. And the reason is that there's a lack of evidence of benefit in patients over the age of 80 if they've never had a cardiac or coronary event. So if they've never had a stroke and they're not using it to prevent a second stroke, or they haven't had a heart attack, the possibility of a GI bleed is significantly greater. So the concern is, if you're going to use it with caution, and really think about whether you're going to use low-dose aspirin. And one of the newer drugs for atrial fibrillation to reduce the risk of stroke instead of warfarin or Coumadin is dabigatran. And initially, it was seen as a great answer to the bleeding risk and the close monitoring and dietary concerns with warfarin. But what was found when the anecdotal reports started to appear was that there is a greater bleeding risk than with warfarin if the patient is older, over the age of 75, and there's no safety or efficacy data if the creatinine clearance, their renal function is deteriorated where the creatinine clearance is less than 30. So it should be used with caution. And in fact, most of the reports that came out in the literature and prompted the FDA Food and Drug Administration review was the fact that there were literature reports of patients dying, falling with intracranial hemorrhages and dying from associated with the use of dabigatran. Antipsychotics, some of the newer antidepressants, carbamazepine, and some chemotherapy agents may cause hyponatremia, which is decreased sodium in the blood, or the syndrome of inappropriate antidiuretic hormone secretion. So the recommendation is if you're starting patients on this drug or you're changing the dose of medication, that you should closely monitor it. And the problem with hyponatremia is that the symptoms are very nonspecific. They could be anorexia, they could be slightly decreased cognition, they could be lethargy. So it's really difficult to tease it out from something else, and that's why the recommendation is to closely monitor these drugs. And finally, vasodilators, because they may exacerbate syncope in patients that have a prior history. So you need to monitor the patient and be careful. The STOP criteria, as I said earlier, were developed in Europe, and they actually compared them to the previous Beers guidelines that were published in 2003. They looked at a little more than 700 elderly hospital admissions, and what they found that their conclusion was that the STOP criteria was a little more sensitive than Beers in terms of picking up potentially inappropriate medications and adverse reactions that caused the hospital admission, where the determination was that the ADR caused the hospital admission almost twice as often in the STOP criteria. If you were to do this today and look at it with the updated Beers criteria, I would guess that with the changes in Beers and the updating, that it would be less likely that there would be a significant difference, and there would be much closer congruence between the two sets of guidelines, because they were taken into account when the group looked at them. So with all this information and all these tools we have, now how do we go about evaluating the list of medications that a patient is on, and how do we go about maybe reducing the polypharmacy? You need to develop an individualized plan with the senior patient. What's the prognosis for this patient and the patient's life expectancy? Are they much further along with a lot of the disease complications than they may have than someone who is earlier in the disease process? What are the goals of therapy? What do you and the patient expect from the drug therapy? And are they realistic? Is it cure? Is it making the patient comfortable and getting rid of some of the most troublesome symptoms of the disease and making them comfortable? How long is the drug going to take to work? If it's COPD and that patient is on a corticosteroid and it takes 10 years, are you going to start them on the drug? Does it make sense? Well, in some patients the answer may be yes, in other patients the answer may be no. So why even prescribe the drug? And what's the strength of the evidence supporting this particular drug therapy? We saw with the diabetes guidelines that when they looked at the studies underlying the diabetes guidelines, that very few of them included the patient population that we're working with and we're taking care of. So are the guidelines valid? Should they be considered as strongly in our patient population as maybe in a patient who fits the inclusion criteria of those clinical trials? And is the patient willing to live with therapy side effects? So if the drug is causing the patient to be tired or causing them not to participate in the kinds of activities that they want, either more time with their family or it's interfering financially, then what can we do to maybe help meet the goals of what they're trying to, the care that they want? So we need to look at these questions and keep them in the back of our mind. One of the first things is we can apply some of the questions from the Medication Appropriateness Index. Is the drug necessary? What's the current rationale for use? The patient's been on this drug for 10 years. Does this mean that the condition still exists? Is the drug producing benefit? I had a patient admitted to the long-term care facility at my previous job, and she came in. I went to the team meeting, and the family came in with a bag of medications, and the physician prescribed all of them because they all appeared to be current, and her blood pressure bottomed out. Well, she wasn't taking all of the medications. So we found that we really needed to look at each drug and determine what was really appropriate and what was essential for her. There was another patient that was admitted on a cholesterol medication, and we looked at her labs, and her cholesterol numbers were so low that we decided to decrease the dose and taper the medication, and we discontinued it because it was no longer necessary. She was no longer cooking. They were no longer getting takeout food. She was on a controlled diet. So these are some of the things to think about. Is the drug causing harm? Are there side effects? Are there drug interactions that may be occurring that are putting the patient at risk? Is it being used to treat a side effect of another drug? And some of those suspect drugs might be an antihistamine, might be an anti-vertigo agent. So you need to look to see what potential side effects there are. Is the drug therapy being adequately monitored? If a patient's put on a medication and it requires monitoring, then we need to do the monitoring. Otherwise, how can we be sure that A, it's effective, and B, that it's still safe? And finally, would there be a difference if the drug were discontinued? So one way that we can do this is we can taper back the dose of the medication gradually, see how the patient responds, and then discontinue it. It can always be added back. So we can have some strategies that will help decrease the number of drugs and the quantity of drugs that the patient is using. The goal of this is really to avoid unnecessary drug use and make sure that the drugs that the patient is on are truly necessary. Review the medication list at each visit for appropriateness. And this is time-consuming, particularly with an older patient. Should it be continued? What's the time to benefit? Use gradual dose reductions. You can work on one drug at a time and get them down and develop a relationship with this patient. You also need to assess any physiologic changes that may occur, such as decreased renal function. We have patients that were started on metformin for diabetes when their renal function was great, and now 10, 15 years later, their renal function has deteriorated. It may warrant a significant dose reduction or discontinuation of the medication entirely. The same with a bisphosphonate. We have patients that were put on Fosamax or alendronate 10 years ago or 12 years ago when their T-scores came back, and now it's 10 years later and their renal function really precludes the use of the drug. And we tend to forget about it because it's been on the med profile so long. We want to also avoid suboptimal prescribing, all those little bits of medications that patients are on. Let's look at what the most critical drugs are to use and work on using those. The limit may be the patient tolerating the medication, but we won't know that until we try it and we increase the dose a little bit if it's needed. But we can take the drugs off slowly and taper them carefully. You can go for the easy wins first. The drugs that were added during a hospitalization or to treat a temporary condition. Most hospitals have a standing list of medications that they add automatically for every patient that's admitted. It doesn't mean that they need to be on them when they go back into the community or they go back to their long-term care facility or assisted living facility. Get rid of the meds unless the patient has a true gastrointestinal condition. Get rid of the proton pump inhibitors. Get rid of the H2 blockers that may have been prescribed for stress ulcer prophylaxis in the hospital. The drugs that may no longer be effective. Patients over time with diabetes progress to insulin. One drug class, sulfonylureas, are meant to promote the pancreas, stimulate the pancreas to increase the amount of insulin being secreted. Well, if the patient can no longer produce insulin on their own, then why are we using a sulfonylurea? That can be gotten off and the patient can be controlled on insulin and a simplified insulin regimen. Is the cholesterol medication still needed? I talked about that patient before. There are other patients. If a patient is a palliative care patient and you're looking to prevent a cardiovascular event in 3 years, is the patient still going to be here in 3 years? The supplements, they have a way of building up. The calcium supplement, the multivitamins. If the patient is taking an oral nutritional supplement, sometimes they're getting adequate intake of these nutrients via the supplements, and they don't need a separate tablet or capsule to swallow. And is the patient having side effects? That's one of the things that you always need to consider. And also, maybe they stop taking a drug and they may not be all that willing to tell you. So you need to develop a level of trust with your senior patient, and also get them to talk about their medications. You also want to consider that any new symptom that the patient may come to the office visit with or tell you about on a home visit is a potential side effect of a medication until it's shown to be otherwise, because we want to avoid treating the symptoms of side effects of medications. The one exception is if the patient is on narcotics, opioids, for pain management, you need to have a bowel regimen in place, and it generally needs to be a standing bowel regimen, because you don't want them to develop severe constipation or fecal impaction. You also want to document the adverse drug events. This helps protect the patient. Some of them may be allergies where they absolutely are not going to get the medication ever again, or a related drug, but most of them are pharmacologic effects, a greater and unintended effect of a normal pharmacologic action of the drug. If you document these, what it tells you later on when you may forget, or the next provider, is that in this patient you want to use caution with this drug. You may want to stick to a lower dose. You may want to choose a different class of medication, let's say, to control their blood pressure or control their diabetes. So it's informational, and it should be posted on the chart, and let the patient know that they should convey that information to other providers. So if we look at another case, we have a functionally independent 75-year-old male with a past medical history of hypertension, diabetes, some osteoarthritis, and urinary incontinence. His mental functioning is pretty decent with a mini-mental of 18. His cholesterol, his LDL, the bad cholesterol, is elevated at 143, but his renal function is good at a serum creatinine of 1, and his diabetes is not all that well controlled with an A1C of 8.7. The meds that he's on are simvastatin for his cholesterol, lisinopril for his blood pressure and diabetes renal protection, oxybutynin for his incontinence, clopropamide for his diabetes, donepezil for his memory, and aspirin as prevention. So right away I see that there's 2 drugs pretty much on the Beers list. The first one is the clopropamide, which is a long-acting diabetes agent. And looking at this patient's kidney function, it's normal, it's good. So my first question as a pharmacist, or maybe as a provider, would be, why is the patient on clopropamide, which was probably started 20 years ago, and not on metformin, which has been shown to control the blood sugar well, not cause hypoglycemia, which is a concern with the clopropamide, and also have mortality benefit. So I would talk to the patient and also review his medical information, and if he did not have a contraindication to the metformin, we would use that. I definitely would not leave him on clopropamide. If he could not be on metformin, then we would select another agent. Maybe another sulfonylurea and up the dose a little bit, because we could get some better control of his blood sugar, probably get the A1C less than 8, or a different class of meds that's going to give us better blood sugar control. Additionally, the oxybutynin is an anticholinergic agent, which is the way that it works to control his incontinence, but it also causes dry mouth, blurry vision, constipation, and urinary retention. So, and can cause confusion. So he's on the donepezil, and the oxybutynin is basically counteracting that drug. So the first thing we're going to do is talk to the patient, find out what kinds of symptoms of urinary incontinence he's having. So is this the best drug? How effective is it? And definitely choose another agent for him based on his symptoms. Now, it's possible that the primary provider can do it, or potentially send him to the urologist for further evaluation. But we would want to get him off the oxybutynin, and if he needed therapy, use something else. Because the patient may have had urinary incontinence, he may have been on a diuretic, a water pill at some point for his blood pressure, and now it's gone, but he's still taking the medication. So we need to tease out what the reasons are and what his clinical status is. In contrast, Mr. L has end-stage heart failure and emphysema, and he's currently maximized in terms of his medical therapy, but he is short of breath and he's hypoxic, and he's admitted to the palliative care service. So the other patient was ambulatory and he was independent. This patient may have different goals of the palliative care service. His current meds include the furosemide, which is a diuretic, metolazone, which is a diuretic, atorvastatin for his cholesterol, lisinopril for his heart failure, isosorbide for the heart failure and chest pain, a Combivent for his breathing, an inhaled corticosteroid for the COPD, theophylline again for his pulmonary, and home oxygen. So in looking at this, we would want to say, what is the benefit, for instance, of the cholesterol medication? Is this something that needs to be continued? And then we certainly would want to keep the diuretic on board because that's probably helping with his symptoms of any kind of fluid retention or pulmonary congestion, as well as the metolazone. The lisinopril for his heart failure, we could leave that alone for now. We would want to know if he's having any chest pain with the isosorbide. We would probably leave that, and certainly the Combivent should probably be on a regularly scheduled regimen rather than making sure it's not as needed or when he has shortness of breath. The inhaled corticosteroid, remember I mentioned earlier that the time to benefit could be as long as 10 years. Is this something that was recently started, and is it still needed? Or are we giving this the medication to the patient, and he's not going to be around to get the benefit of it? Similarly, the theophylline requires close monitoring. It has a fair number of drug interactions, but we need to do regular blood work to make sure that the serum levels are okay. So is this something that's needed, or could it be reevaluated? So there's a couple of medications here that, looking at the goals of this patient at this point in time, are probably to be made comfortable and pain-free. So we want to look at the meds with that in mind and discussing it with the patient and the family to determine what's appropriate to continue and what might be appropriate to discontinue or change. So what we want to do overall is individualized therapy to the patient, review the medications regularly to see what we can discontinue or taper, involve the patient and or the caregiver so that there's buy-in and they understand why the meds might be taken away or decreased, and use medication reconciliation to convey the accurate information so that the patient is aware of the meds that they're on and they can communicate with other providers. And the goal of all of the effort should be to treat patients, not lab tests or treatment guidelines. So with that, I'd like to conclude and thank you for listening and answer any questions that you may have at this point. Thank you.
Microphones are enabled.
Dr. Stamati, this is Elise Perweiler from New Jersey. I just would like to thank you for a very comprehensive presentation. I was particularly glad that you added the stop criteria into the beers because a lot of times people don't even think about that and the stop, but we have likewise here found to be a little bit more sensitive. The other thing I was happy about was that you talked about breaking the prescribing cascade. That's a big challenge for us in our geriatric practice, especially in long-term care, but even in the ambulatory care setting, it's a real challenge. So thank you very much for that.
I'm glad that you appreciate it. That's one of the challenges we have here, both in the CLC, the Community Living Center, and the ambulatory patients. Sometimes when I open a med profile, I'm sitting there and I'm scrolling through and I'm sitting there counting the meds and I can't believe what I'm seeing on the screen. We actually implemented medication rounds here with the nurse practitioners in the Community Living Center, and we sit down, we pick a few patients every week, and we sit down and go through them drug by drug. And we prefer when they bring up patients that they have questions about, but we also bring up patients. And most times we're able to do maybe one medication at a time, which is fine. and gradually we'll come back to them and work on it. Oftentimes you have to get buy-in from the family members and from the patients in terms of willing to give it up. The challenge we're working on now is the sliding scale insulin. And we've done some in-services, but we feel it's going to be a year-long project to start to reduce that. And likewise, getting someone who's focused on it in an outpatient setting is important to the success and work with the team.
Mm-hmm. I really agree that that's important. I think as we get into more of this interprofessional collaborative practice, the value of having a pharmacist involved with the primary care providers as a key member of the team is critical.
I agree.
I know that there was a question in the chat that I saw earlier, and it was regarding about whether or not you ask about alcohol and drug use in these patients.
We do, and we do certainly in the outpatient setting when the pharmacist sees them. It also comes up as a reminder for the provider regularly. And depending on what they answer, if they say yes, then it comes up, I believe, at every visit. If they say no, I think it comes up at least annually. But they are screened in the CLC. They are also screened. And one of the things we're actually struggling now within the long-term care facility is an alcohol use policy. And the transition to a more home-like environment. So that's one of the things that we're working on now with the team in the interdisciplinary and the transformational change team in the community living center.
Oh, that'll be interesting to find out how that comes out. I mean, many of the higher end community living centers do offer a cocktail hour.
Right, right. And one of the challenges is in a veteran population, there is a certain percentage of vets that are in the community living center that have a history of alcohol abuse. And how do you handle that? So,
exactly.
Definitely a work in progress.
Mm-hmm. I also noticed that Denise Mohess had asked a question about over-the-counter meds or alternative meds or supplements, and that they often go unreported or undocumented. Do you come across that frequently in your medication reviews?
We do. We encourage the provider in the VA has the ability to put these outside supplements. We have a complete list in as a non-VA med and whether or not they recommended it. Sometimes if I'm in the clinic or a pharmacist is in the clinic, the provider will alert them because they know that the veteran is a heavy user of alternative medications, and we'll sit down with them. And you really have to be careful about how you do it with them, because if you tell the individual, well, you don't use any supplements, they're no good, they'll shut down. So the approach that I found that works is you sit down and you find out what they're on. And you start to, do they know why are they using it? What's the rationale? And then you can start from there, because if they don't remember why they're using it, you could start to chip away at that. Sometimes lab values, I had one patient that was taking vitamin B12, high-dose vitamin B12, and we actually had a lab that showed his number was off the charts, and he agreed to stop taking it after he saw the lab. So you have to use some creative strategies to get the patient to trust you so that you could start to wean that list of nutritional supplements or herbals down. You look for potential drug interactions, but we do list them we put them in our progress notes, but we also list them as non-VA meds in the chart. So it's there and it runs through the drug interactions package.
I noticed that there were a couple of comments in the chat. I don't know if you see them, from Donna Lisi, who actually is a pharmacist, and I thought that those were very good questions. Perhaps you might want to address those.
Okay. Yes. Inhalation quotas. Right, and the thing is, you need to be careful about it. One of the things you might not do is you might not start an inhaled corticosteroid in a COPD patient if they're palliative care. It could be discontinued. It depends if the patient is symptomatic or not. You would not want to make too many changes at the same time. You'd want to be careful. So there is some leeway. Nothing is written in stone, but if you look at the time to benefit, it may not be there. So you want to be careful that you don't exacerbate an event, exacerbate a COPD, but you also can consider it if the patient is somebody who is not, let's say, poorly controlled and is basically asymptomatic.
Yeah. Thank you. Donna also raised the question of withdrawal of the protein pump inhibitor and some of the challenges or things that may arise that we may not be aware of.
Right, and one of the things that we always ask about is what do you use if they don't mention it? What do you use for pain or a headache? Is there anything that you take? And that's how you tease out that maybe they're taking the over-the-counter Aleve or ibuprofen. So then that could factor into keeping the PPI on board, keeping the gastrointestinal protective agent on board. That's why you really have to sit down and talk to the patient. So, and if it started in the hospital, well, why were they in the hospital? Was it gastrointestinal related or wasn't it? So you have to get to know the individual that you're dealing with, and also take an individualized look. But some of those are the target drugs that we might consider for discontinuation. It doesn't mean that every single one would be discontinued, and we see that often when we do medication rounds in the nursing home, that we may have identified certain drugs and asked questions about them, and the nurse practitioner or the physician who's involved may say, well, so not everything is in the chart, so it can't just be a chart review. It has to be a discussion.
Well, I thank you very, very much, and on behalf of all of us, we've seen a lot of comments about how appreciative everyone was of this very informative and excellent presentation, and we thank you for your time, and I think we're all leaving better educated.
Thank you very much, and thank you for having me.